Kaveh Safavi. I'm one of the global leaders at Accenture. I'm a doctor by original training. I spend my time working with organizations trying to help them understand how to combine the promise of technology and human ingenuity to solve big, hard, intractable problems. I've had the pleasure of working in about 25 countries over the last 2 decades. I work with every kind of organization, providers, funders, governments, companies that are trying to figure out what to do in healthcare. It's been a very interesting professional life.
Yeah, you certainly bring that global perspective. So what brings you here to Kirikirioa, Hamilton?
Well, so we're rebuilding our presence as a business here. We've been here for a few years. I was here last year at the same event. And just because it's such an important event for the leadership, both the private and the public sector, it's an opportunity to hear and share what people are doing and thinking. So it's always good to be here.
Perfect. Delighted to have you. So tell us a little bit about your plenary presentation this morning.
So I was specifically asked to address the issue of how technology is affecting work. The context fits very well with the priorities in New Zealand. As Commissioner Levy yesterday said, the top 3 priorities, the first 2 were an access problem, a waiting time problem, and a labor productivity problem. Every country I've been to this year, it's the same issue. I've been in 5 continents and 14 countries in the last 12 months, and the issue of access and labor productivity have become the number one healthcare system issue because of demographics. And so we see this problem of the demand for care growing faster than the supply of caregivers. And the question is, how are we going to close that? Because if we don't, we're going to have a serious societal issue of a lack of access. Our hypothesis is because there's not enough human beings in the workforce, you're going to have to take what people do and use technology to actually scale human capacity. The jobs that technology can do go to technology, leaving the humans to do the things that humans can do. That's the mental model. We did not really have a good answer for it until generative AI showed up, because generative AI gave us the ability for technology to take over language tasks, reading and writing, which turns out to be 40% of all tasks for all jobs. Within healthcare provision, it's in the 20s. That gives us the ability to give people time back, as much as 20% of their time, so that they can do other things, including serve more patients. Because ultimately, if we did it the way we did it, people would have to wait. And the implication there, though, is not only do you need the technology, but you actually need to change the way the human works, because you've actually reorganized their task lists. So jobs are different, organizational structures are different, and the skills of the people are different. And so I covered the implications of the problem, the nature of technology, and then how the work has to change in order to reflect and gain societal benefit.
Yeah, it was a fascinating presentation. And yeah, I think that you put up a slide, saying if we had 10 nurses, how might we rearrange this?
Yes.
And so you had 6 nurses still, and then 4 bots or AI agents. And I thought the most interesting thing was that those 6 nurses are going to be doing a different job.
Yes.
And so the leadership of that and understanding how to lead a team that includes both humans and agents or bots is going to be very different as well. And it's all a cultural shift and a mind shift.
Right.
And so how do you sort of go on that journey?
That's actually the hardest part, the change management. The technology is the catalyst. It's necessary but not sufficient. The presence of technology, if you just added and didn't change the work, you actually make things worse. We can call this broadly change management, but it has many levels. So like, for example, the first level we're seeing is an immediate need for a basic technology vocabulary or technology literacy for everyone. An organization in the U.S., for example, that's trying to bring virtual nursing in, and I know this organization, the leader there, the clinical leader, told me he realized that the nurses don't understand the words. So he needed to introduce basic technology literacy, like when I say virtual nurse, I mean X, before he could introduce it to them as far as their work. And we're seeing this in every industry, is technology literacy is becoming a basic requirement for people in their jobs. The next level that often it comes into play is who's in charge of solving this problem for me? The traditional organizational silos, I have an IT department, I have an HR department, those departments can't be responsible for this. The operators have to be, but the operators were never selected for this skill set. So I had a CEO of one of the largest health systems in the U.S. tell me, Kaveh, I understand what you're saying. My problem is I don't know who to give this problem to. So we're starting to see organizations address their broader operating model. Who do I give this job to? What are their skill sets? What's the transitional model? Where does change occur? That's all happening at the same time. The technology is just arriving, so the nature of changing individual jobs hasn't really begun, although it has begun in some areas, like physicians are have more experiences with the ambient documentation or inbox management. They're getting some time back, so they're starting to learn what to do with it, but that's kind of the horizon that's still to come. So we're really in the early days of this. I think this is a decade of effort.
Yeah, and you spoke about how healthcare's, if not the only, one of the only industries where the addition of technology has actually reduced productivity, which I thought was really interesting. 13% of time taken up by taking notes and typing to a computer. So we have, we are at the early stages of adopting AI scribes, medical scribes into healthcare in New Zealand and overseas. Is that sort of the first step into this transition then?
Well, for physicians in particular, it's a big time relief for them because it does two things. It's not just a transcription. If you think about the way a doctor today works, we have a conversation. I'm a doctor, you're a patient. We have a conversation. And then I stop and I intentionally recharacterize what we just said into a note, and then I document that note. The machine is doing both of those things. It's listening to our conversation in real time, and it's recharacterizing it. So it recognizes that something that we said in minute 1 and something we said in minute 18 are actually related. It's not just a verbatim recording of what happened. It's the way I would stop and rewrite the note in an organized fashion. Yeah. So that's a very different kind of a thing than simple transcription. But it actually goes beyond that. So it gives me that time back, both the thought time and the type time. But it also can take that information, and then from there it can push structured information out. So the information I need for analytics, decision support, all of those things which is why I made doctors type, it generates that.
Yeah.
So we're getting the narrative and we're getting the structured data out at the same time.
Yeah.
It's pretty powerful.
And in terms of what people can do to start planning for this change and make sure that it doesn't sort of happen to us, but happens with us, what kind of advice do you give around that?
Well, it's going to be hard to happen to us because it's really about our jobs. So we're seeing three kinds of things happening. The first one is all of this stuff sits on a basic technology foundation that, frankly, healthcare as a general statement is underinvested in compared to other sectors. And then at the country level, it's even more underinvested. New Zealand, as an example, on a relative scale of rich countries, is more underinvested than other rich countries are. So no foundation to build a house. So this becomes a real call to action, because otherwise we're going to admire these technologies as they become available because we have nothing to rest them on. So that's the first one. The second one is that because we're going to be using artificial intelligence, and artificial intelligence has a number of implications, we actually have to have a perspective on responsible artificial intelligence before we bring the technology in. And this idea that you have to think about that in advance is not usually the way most of the time people played around, experimented, and then maybe they got around to responsible artificial intelligence. But the truth is that the choices you're going to make about how you're going to use technology, where you're going to use it, what you're going to use, has to be anchored in something. And if you don't have it, and I've seen this, organizations, technology organization or innovation organization ran ahead and said, hey, look what we can do. But then the organization's compliance and privacy group said, I don't know what you're talking about. We are never doing it that way. You got to go rebuild the whole thing. We never had the conversation about responsible artificial intelligence. So that's an immediate thing to do while we're waiting. The third one is this issue of who am I going to give this problem to? To have a theory, and that's a chief executive level kind of a problem. That's not a ground level management kind of a problem. What we're realizing now is that this transformation only works if the chief executive or the chief executive type people believe it's their biggest problem. All of the organizations in every industry that I've seen, not just health, that are the farthest ahead, the loudest cheerleader is the chief executive.